Thank you for joining the New England Nursing Home Quality Care Collaborative. My name is Sarah Drenick, and this is part 2 of the 2-part webinar series, QAPI, Process, Plan, and Outcomes. Today, we will be hearing from Sandy Fitzler, who will address some questions from part 1, specifically those related to the new regulations and how they impact the requirements for training. We also have Florence Johnson on, who will be presenting on behalf of one of our high-performing nursing homes in Connecticut on their QAPI program, highlighting a successful PIP. And then we'll also be hearing from Katie Lasowitz. She is from Beechwood Post-Acute and Transitional Care, who will be presenting on 2 successful PIPs that they rolled out in their facility. Now, before introducing our first speaker, I'm going to quickly review a few housekeeping items. This webinar will be recorded, and the presentation will be available within a few business days. The phone lines will be on mute for the duration of the presentation, and we ask that you do not put your line on hold. If you have a question at any point during the presentation, please enter it into the chat panel to the right of your screen. Please make sure to send comments to all participants, as we will be monitoring and responding to your questions and comments in chat. We will also have plenty of time for questions at the end of the presentation. Lastly, if you find that the presentation is a little cut off, please use the plus or minus icons in the top right of the presentation window to adjust your screen accordingly. Now I'm happy to introduce Sandy Fitzler. Sandy?
Hello, everyone, and welcome to today's webinar. And Sarah just went over the agenda, but here's what we have. Looking at the final rule on training, and then from 2 facilities, we're going to learn about their QAPI program and leave some time to you for questions. Now, this is really not a polling question, but we would like for you to elaborate in chat, so send us what you have. But since the first webinar, have you made any revisions to your QAPI or PIP teams? And we want to know that, so just put it into your chat and send it along. Okay, the impact of the final rule on training. Why do we have this today? Well, this was one of the questions that came up in the first webinar. The person who asked the question identified that there were a lot of issues around training, and it was kind of confusing. So we're hoping to touch upon that a little bit today and make a little bit more sense out of it. The question does relate to the CMS regulation on training, and CMS has put forth that effective training, and that is a new section that will be a requirement that the program, you'll have to have an effective training program for all new and existing staff, contractors, and volunteers consistent with their expected roles. Okay, so what has CMS done? What they have done is they have identified training, but they have done it in via 3 phases when the requirements will be effective. There are several requirements over the next 3 years that will require facilities to train staff on programs and procedures and regulatory standards. Some of the training is already required, but requirements for long-term care facility reform has added some minor tweaks. So not all of this is training related, and they added it to the current requirements. I think it's important for everyone to keep in mind that the CMS interpretive guidance is not due to be released until this summer, and that should give us more direction on what to include in the training program. So let's look at phase 1. What you're supposed to have done this year, and I know from talking to many of you, you're already doing this, resident rights and facility responsibility, and you must ensure that staff members are educated on the rights of residents and responsibility of the facility to properly care for the resident. And abuse, neglect, and exploitation, you must educate staff on the activities that contribute to abuse, neglect, and exploitation, and misappropriation of resident property. and the procedures for reporting these events. So what is required this year? Well, this is our second webinar on QAPI, so it's no shock to find QAPI and infection control that's required for this year. It mandates training as part of your QAPI and infection control prevention and control programs that educate staff on the written standards, the policies and procedures for each. So that's QAPI and antibiotic stewardship. Resident rights and facility. Well, we just had this one, and the only new and minor change occurring this November is that facilities must add information on resources for reporting issues, and this is like the Aging and Disability Resource Center or the Medicaid Fraud Control Unit. Compliance and ethics programs requires program standards training and responding to violations. So we're waiting for the interpretive guidance because standards training is something that needs to be defined, and I'm sure the interpretive guidance will give a little bit more on the definition to that. Abuse and neglect adds regulation for reporting reasonable suspicion of a crime. Again, reasonable suspicion is a definition issue, and, what we see in interpretive guidance will further define that. CNA in-service training requires dementia management and resident abuse prevention to be part of a 12-hour per year in-service training for CNA. And behavioral health requires facilities to provide behavioral health training to the entire staff and includes training on non-pharmacological interventions. All right, and what is going to be required in 2019? Well, we have behavioral health again, but it adds to training about residents with a history of trauma and post-traumatic stress disorders. Under your QA and QAPI and infection control, your QAPI must be involved in review of allegations and incidents of abuse, neglect, and exploitation. So I am assuming under this that you're looking to see if your QAPI effort is addressing this, and if you need a PIP, you've developed a PIP for incidents. And it does add the infection preventionist to be a member of your QA&A or your QI committee. Compliance and ethics program requires annual training if the organization operates 5 or more facilities. And communication, and this is the issue that I think our person asking the question was really focusing on, but requires facilities to include effective communications as a mandatory training for direct care staff. Again, effective communication is a definition issue. Interpretive guidance will give us more information on what may be required for this. And of course, keep in mind that this is not required until 2019. So we do have some available resources for what is required this year. This is CNA in-service training on dementia management and resident abuse prevention and behavioral health. And if you're looking to find things that should be included in your training program, we have 3. The first is Habilitation Therapy Toolkit. This was developed under a CMS Innovation Grant study involving 30 facilities in Massachusetts. It's a resource. It's a competency-based approach to training staff on caring for individuals with dementia and without the need for antipsychotic medication. The second resource you have is the CMS resource, the National Partnership to Improve Dementia Care. And if you click on that link, you will have access to several surveys and support letters, webinars, videos and they all pertain to dementia care, behavioral health, and antipsychotic medication reduction. And the third resource is OASIS. That is a DPH, Department of Public Health, funded dementia care and antipsychotic education program that was developed by Mass Senior Care and many facilities in Massachusetts and Vermont were involved in that training. So some really good resources available if you're looking for that now. Okay, for our first polling question, we have, did your team identify a project to focus on after the first webinar? Yes or no? And so while I'm waiting for your responses, I am going to turn this over to Florence.
And don't forget to hit the submit button once you've picked your choice. You have to hit submit.
Florence, you beat me to it.
You trained me well.
And Florence, the ball is now passed over to you.
Thank you. So while we're waiting for the polling question to close, I just want to put a disclaimer out there that I'm at a nursing facility today presenting, so I apologize in advance if there's any paging or connectivity issues. So I put that out ahead of time. Okay, great. 33 people have made some adjustments. That's really, really good. Hopefully the 53 that had no answer, you just forgot to hit the submit button. But we'll keep working on it. I have the honor of presenting for Jennifer Sargman today. She experienced an unexpected family emergency, so she couldn't be with us. I would try to do some justice to her presentation, and any follow-up questions that I'm unable to answer, we will gather those and send them to her, and when she responds, we'll send it out to the participants. Jennifer works at Milford Healthcare and Rehab Center. It's a 120-bed facility. They have 32 beds that are short-term rehab that focuses on joints, CHF, and pulmonary programs. It's a 5-star building, and they have 5-star quality measures. This facility is in the southern part of Connecticut, and they are part of a preferred provider of one of our big healthcare systems. So for their QAPI projects, they actually have developed a QAPI program using the design and scope as part of the beginnings of their work. What they do is they see themselves as touching people's lives. It is their mission to provide their residents and their families with superior care that's delivered by staff who's dedicated to the principles of kindness, compassion, service, excellence, in an environment where the individuality, dignity, and value of those who they serve, as well as those, the value of those who serve, as well as those who are served, is nurtured and appreciated. They believe that life at all stages and with all its challenges is a precious gift to be shared and celebrated. It is their privilege to participate in the lives of all their residents and their friends and families by offering them not only physical but emotional care, comfort, and support. So part of their governance and leadership is the administrator, the director of nursing, are accountable for overseeing this committee. And we talked about committees and PIP teams 2 weeks ago. The governance and leadership provides annual education on the purpose of the committee, and how participation in programs should be focused and what the area of education should be. To make their residents, families, and visitors aware of what's going on in their building in the true sense of QAPI, they have storyboards, posters, pamphlets, newsletters, and staff meetings to make sure that everyone is on the same level of knowledge of what's going on in their building. So in the part of QAPI that talks about feedback and data and monitoring, they use their CASPER reports, their quality indicators, and part of their EHR, they have a long-term care trend tracker that they also use. They use the Pinnacle interviews, Strive for 5 interviews, and these are all personalized programs that their corporate entity provides for them. They use food questionnaires, interact trending. Being an educator, I'm glad to hear that they're using interact. And they also have an ambassador program. They have monthly quality risk council meetings where they look at key performance improvement areas that is set by the company as well as data that's gathered from multiple sources. Performance improvement projects were selected based on quality standards that's set by the team using CMS guidelines. So they looked at, for instance, they looked at residents with moderate to severe pain. They are currently at less than 10%. And facility-acquired pressure ulcers are less than 2%. The Quality Risk Council meetings are held monthly, and this is, I'm not sure if you can see this clearly, but this is what they use, their tool, to make sure they stay focused on what they're working on, who owns the process, what's the status of the key performance indicator, and then using SMART goals. And then at the very end, they talk about their results. So they use this tool every month to keep them on track. So how do they analyze and approach the problem? They use reasoning mapping to get down to the root cause of the issue. They focus on the why, which I love as a QI person. They drill down to priority reasons why issues have occurred. They formulate and implement a PIP. The PIP is updated as needed, and then every month at their QRC meeting, they review the data. So this is kind of their map. They look at the KPI, the key performance indicators, and then look at possible reasons why this problem is occurring. And then they build out their priority reasons, their 30-day goals, and how they're going to get there. So this is literally their roadmap. So one of the tips that they built, that they focused on, was pressure ulcers. Their goal was to get down to less than 2% on facility-acquired pressure ulcers. When they started looking at this, they were averaging 3% over a 3-month period before implementing their tip. After implementation, they were able to reduce facility-acquired pressure ulcers to less than 1%. And don't worry about this. We will send the slides out to you, or if you haven't downloaded it already, you will receive these after the webinar. But their key performance indicator was the facility of prior pressure ulcers. And then the possible reasons. Lack of risk identification for those residents that were at risk. They had care guidelines may not be reflective of the accuracy of the resident's current condition. Preventive measures may not have been in place. There might have been discrepancies in orders. So did they have heel boots versus pillows? Staff was not able to identify those at higher risk for a pressure breakdown. And then was the grading scale not as accurate as it should have been? So they took all those and broke it down to 3 areas of likely reasons why they were having these pressure ulcers. The care plans or care guides may not have reflected the accuracy of the resident's current condition. So are you improving and updating the care plan? Identification of those residents at risk. So someone might be having a breakdown or they're not catching the skin issue early enough. So an area that's red, we shouldn't just chalk that up to, it's just from them leaning against something, but really drilling down to where did that come from. And preventive measures were placed in all areas. And then the priority reason was care guides were not reflective of the accuracy of the resident. So it wasn't painting a perfect picture. And then the 30-day goal was, upon reading care guides, CNAs will identify those residents at risk for skin breakdown and their preventative measures. This is really great that they included the CNAs because those are the people who provide hands-on care in a lot of the skin care. How did they get there? The infection control numbers started at each resident and compiled a list of those residents at risk for skin breakdown. Each resident at risk for breakdown will have a preventive measure that's identified in the care guide, care plan, as well as the the treatment administration record. So not just for the CNA, everybody globally needs to understand who's at risk. Each unit was supplied with, each unit has to supply a list of residents who was on an alternating mattress, heel lift, anyone that had a device to prevent pressure ulcers has to be identified and given to the infection control nurse, and this was updated monthly. The infection control nurse will then audit for accurate orders and preventive needs based on the risk of the resident. And then monthly reviews at their committee meetings, and the findings and the trending is shared with everyone. Again, this is difficult to read, but it basically breaks down how the facility of prior pressure ulcers were able to be decreased to below 1. And I know I'm not going to do this justice because she lived it. Of course, when you're doing quality improvement, you will always encounter some barriers. And one of the barriers that they encountered was that teams wanted to focus on how to fix an issue as opposed to looking at why did it happen. I love that this was her number 1 because when I'm working with people, this is what I see. Everyone wants to give a response to what the problem is instead of looking and drilling down, asking those whys. Another barrier is just picking up one reason why the issue was occurring. Their hope is to implement a plan that improves one reason will trickle down to another reason. So again, asking those 5 whys, or asking the whys until you cannot ask any more whys. Barriers was it takes focused time. It takes focus and time to improve, and people tend to want to make it happen yesterday. So, their success, they were able to drop to 0.9%, which was a lot better than what their original goal was. The staff was able to identify those at risk, and preventive measures were put in place. My hope is that Jennifer and her team really celebrated themselves, because this is awesome work. So anyone have any questions for me? I'll do my best to answer them.
Florence, for right now, people are still on mute, so maybe we could save those questions for the end. Yep.
Okay.
In the meantime, if anyone has any questions, you can ask it in chat or wait until our question and answers period at the end.
My turn, I guess. Hi, everyone. I'm Katie Lazarus. I'm the administrator at Beechwood in New London, and I have Natasha Hurt. She's my director of nursing sitting with me. I'm going to go through the presentation, but any questions, she'll probably be better at answering them than I am. So Beechwood Post-Acute and Transitional and Long-Term Care is a 60-bed facility. We are short-term and long-term, 30 beds for short-term with 2 dedicated hospice beds in that 30 beds and 30 beds for long-term care. We're independently owned, and we live and breathe QAPI. It's something that my predecessor, Qapi, put into place, and we've been living and breathing it from the beginning. So QAPI, one thing that we have on our wall downstairs for our staff is tell me and I forget, teach me and I may remember, involve me and I will remember. So it's something that just is part of our culture and our being here at Beechwood right now. So much so that we sit in our morning meetings and the staff says, oh, we need to QAPI that. Time to do that now, and brings it up in that manner. So our QAPI committee, it doubles as our medical staff meeting quarterly and involves our physician, our APRN, our interdisciplinary team, and the vendors that come to our meetings. But we also, anytime in between, if the need arises, it's initiated by our interdisciplinary team in morning report and at our weekly at-risk meeting as well. So those are the 2 areas that kind of bring it into more of a real-time focus. We analyze our data. We use My Interview, which is our satisfaction survey. We use Contractor, the Interact reviews. Casper reporting is the biggest piece that we use to identify any issues that we have going on, and we also have a new system that we've been using for the past 5 or 6 months now, and it's called Real-Time Medical Solutions, which pulls out of our medical record into real time all of those Casper reporting quality measures so that we can look at them real time before they actually go up to CMS from our MDS process. So those are the tools that we use. So our current and last year tips that we have, this is just a few, not all. We revisited our STEAM table dining program. That team named themselves the STEAM team. We are constantly, obviously, looking at our rehospitalization rate, but it was a focus last year. Our discharge process was a PIP. Employee injury and body mechanics, that team named themselves the Body Safety Champ. And we actually significantly reduced our workplace injuries in the past year and a half. Elopement was a PIP. Quality measures, obviously, is a focus for everybody. Satisfaction survey rates is another one. Pressure ulcers, which I'm going to talk about, and alarm reduction I'll talk about as well. And right now we have some active ones. Our grievance process is a copy that we just, QAPI that we just did, and a lot of the mega rule changes are things that we're putting into place as QAPIs and PIPs. So first, our pressure ulcer reduction. We identified through our Casper and our quality measures that our short-term and long-term rates were increasing. Our long-stay residents with high-risk pressure ulcers, quarter 1 of 2016 was 6.9%, quarter 2 went to 11.1%, and quarter 3 was 12.9%, and for short stay, it was, for all 3 quarters, was 1.3%. And previously, we were using our goal setting, using the SMART formula to reduce percentages, and our goal was to reduce it below the state average and improve the quality measures. So we initiated a root cause analysis with our interdisciplinary team to overall improve those numbers significantly. And in that root cause analysis, and drilling down to everything, we looked with our instructor in housekeeping and nursing and looked at our wound care products were not doing the job that they needed to do in the actual application of those products. The equipment we had in-house was old or ineffective and needed to either be replaced or used in a different manner, and then the skincare process needed to be looked at as well. All of those factors were leading to those increases in the pressure ulcer rates. So our implementation, it did take us a good 6 months to get everything into place. But first we evaluated our current wound protocol, skin protocol, and ultimately that ended up in a vendor switch for us. We switched vendors, and the new vendor put in a whole new wound protocol for us with new products and a better skin product as well, which has been extremely successful for us at this point, and all of the nursing staff had to be retrained. So both the RNs and LPNs and the CNAs had to be retrained on all the protocols and turning and positioning and everything that was involved in that. And then we evaluated our equipment, and what we realized was that the heel managers that we had in place were not effective. And we found a new product that was better and more effective and put those into place, as well as our mattresses. In our digging down, some of our mattresses hadn't been replaced in over 10 years. So we worked to replace some of the old mattresses, and we also put into place new mattresses that are actually pressure-reducing mattresses as well. So our goal for quarter 4 was to show a reduction once all those pieces were in place. And I am happy to say that our quarter 4 data for our long-stay residents, 0% pressure ulcer rate, and short stay was 1%. And then quarter 1, right now that we just finished and wrapped up, our long stay, I have a little star next to this because one of the gentlemen that came in with a ulcer from the hospital and needed surgery, I'm working with our MDS coordinator and our consultant right now. I think that number is going to be 0 because I think it's a miscoding kind of issue. And our short stay rate is at 0%. So we are extremely, extremely happy with these results. But it did take, this was a very, very long PIP and took a long time for us to actually see those results. All right, so our second PIP was alarm reduction. Natasha, my director of nursing, came in January, and it was one of those things that she wanted to do to improve the quality of life here at Beechwood. So we were hoping to improve the quality of life and potentially reduce falls. Our IDT team was the initial team to discuss this, and we worked to use the SMART formula to put in a plan to reduce the alarms. Okay, so root cause analysis. Natasha held nursing learning circles and meetings, and both with the nursing CNAs and then separately the RNs and the LPNs to identify 3 to 5 residents at a time to remove alarms. And alternative intervention education was given at that time in those meetings about what to do in place of the alarm. We sent a letter and information to the families and had them reach out if they had any concerns. And actually, I don't think we really had many families that had concerns. Ultimately, ended up being 2 and 2 residents that we could not remove the alarms from. And then all of our other staff, dietary, housekeeping, maintenance, recreation, the office staff were all educated on alarm reduction and things to look for and know who was of all risk. Each month a review was done, and the team, and it really was driven mostly by the CNAs, who was identified to be taken off next. So generally it was 3 to 5 people at any given time. So we initiated at the end of March. By the end of August, we had everyone off of alarms except for those 2 residents that the family and the facility felt we couldn't remove. And by October, we were completely alarm-free. Our falls have decreased. What we've noticed is that the long-term residents that used to be repeat fallers are no longer falling in repeat patterns, and it's more just new residents coming in that have those initial falls and then they don't repeat after that. So it's been a successful implementation. The challenges for that one was really getting the staff buy-in. Natasha kept finding alarms hidden throughout the building, and we had, I think, maybe 2 nurses that were very, very resistant to the change. And needless to say, we had to do a lot of searches and throw out a lot of alarms to get that reduced. And then challenges with the pressure ulcer reduction was a lot of education, and it just took a lot of time getting all of the things into place, everyone educated on it to really make it the most effective program possible. So that's what we have. I'm going to throw the ball back to Sarah.
Thank you. At this time, we'll be addressing any questions. To unmute your line and ask a question, dial #6, and you'll be free to speak. Also, you can submit a question using the chat panel on the right of your screen.
This is Sandy. While we're waiting for questions to come in, I have a question for both Katie and Florence. I love the facilities approach. It's excellent. My only question is, in the list of sources used to identify potential problems, I didn't hear it mentioned that you were using incident or complaint reports. Can you elaborate on that a little bit?
Like the accident and investigation reports internally?
Yeah.
Yeah, that's part of our, for D2, it's part of our at-risk meeting. So weekly we review falls, well, we review the accidents reports when they happen, but Natasha then pulls the data together, and that's part of our at-risk meeting weekly. So it does identify those trends, and at the end of the month too.
Good. Florence, do you know?
I'm pretty sure that they incorporate that into their KPI, the key performance indicators. I can't honestly speak.
Okay, then this is good to hear. My only recommendation would be then to identify those specific resources when you're looking at all the resources you use to identify problems. And the rationale behind this is I mentioned earlier that in 2019, when you look at QAPI, your QAPI must be involved in allegations and incidents of abuse, neglect, and exploitation. So this is one way to show that you are regularly monitoring where those issues might pop up, and that's why I just put it on your list now, because I know you're all doing it, but just add it to your list that you review it on a regular basis.
Thank you, Sandy. We have a question in chat for Katie. It's from Christine. What is the tool that you use to see the QM measure data from the MDSs before they're submitted to CMS?
So we purchased another system that has a monthly software fee that is called Real-Time Medical Solutions that pulls out of our electronic medical record and pulls those items out and triggers, so we can pull a report daily to see who is triggering on that. But I also use, once the MDS is actually, so that's to get it before you actually finish the MDS. So we're looking at somebody who had a mobility decline and trying to see whether it's a coding issue and the aide didn't code it right, or if that person truly had a decline overnight, and look at it in real time. But prior to, after the MDS is submitted, you can go into the CASPER online system, and you can look at your data on the CASPER report, and then there's that sheet that comes out once a month before the new quality measure report is posted, that you can double check to make sure everything was coded accurately before it gets submitted in those nice monthly reports that we get now. So both of those items.
Great, thank you, Katie. And then in terms of, and this isn't real-time data, but when you pull your reports in Casper, you can pull monthly, quarterly, whatever time frame you choose to look at your quality measures. As a participant in the Learning Collaborative that the New England QIN-QIO is hosting, you will be receiving, or you should be receiving, your quarterly standard analytic report that shows trending. So when you go into Casper, you can only see where your quality measure is at that given time, that time period that you selected. This report is really helpful for you to really track over time to see, are you improving? And also at the same time, identify QMs that might be going in the wrong direction that you might want to start a new PIP on, or at least investigate to see what's going on with that QM. We do have another question in chat from Bruce. His question is, what is the SMART formula?
So we, from CMS, we have been using, and I'm actually changing this to the PIP formula now based on that new releases, but QAPI goal setting worksheet that we've gotten off of CMS's information from Allie from Florence a long time ago. And the SMART formula is S is specific, M is measurable, A is attainable, R is relevant, and T is time-bound. So there are questions under each of those as to how you're going to move forward with your process improvement. But I just started using the PIP form instead, and I like that a little bit better.
But your goals on your PIP form for your QAPI program are essentially SMART goals.
Yeah. Essentially, yep.
Did we have anyone on the line that had a question to ask? Again, just a reminder to unmute your line, press #6, and then you'll be free to ask your question. We have a question?
We're interested in doing a PIP for alarm reduction, so we're interested to know what steps were taken at Beechwood to give that facility confidence enough to remove all but 2 of the alarms.
I'm the director. I had done this in a previous facility before, and basically when I came in, I believe that we had 33 alarms in the building out of 60 beds, and it was insane. So basically that was my reason for it. It was too loud. Falls were happening at a rapid pace, whether they had alarms on or not. Most of the A9s that we got all said alarm sounding when they found a patient on the floor. And that was the basic reason. That's what initiated the whole thing, and I knew that it could be done. It's just a matter of getting the staff buy-in to do it.
And I watched some of those meetings, and it took time. So she fully introduced it. So the first meeting wasn't even about we're going to do it. She just started bringing up the topic and asking them, well, would this have prevented it, and would this have changed it? And a lot of the CNAs were actually very much on board. It was more the nurses that we had a little bit more of a problem getting the buy-in from, and it was really just constant repetition, and once we showed a couple people that it did work for, then they continued from there.
Was there something specific, maybe a couple of steps specifics that were done in terms of education of the staff to prevent falls and give you the confidence to reduce the alarms by that great number?
So I did give them some background information that I had found online. I can't specify what the source is at this point. But there were brochures that we gave to families. There were brochures that I made available to staff. It showed some of the statistics on actual alarm use and the fact that they don't reduce falls. And they don't stop people from falling. They just let you know when they're on the ground. There was also some research out that showed that alarms are bordering on the line of being a restraint in some form. So I had to change the way that they looked at an alarm, and that's how we started. And that's where we went from there.
And we can send that brochure to Florence, and she can potentially give it out.
Thank you.
Do we have somebody else on the line that has a question?
So there's a question in chat.
So I saw that there was an additional question that Bruce asked. I missed the QAPI Part 1 webinar. Is there a way I can access the materials? Yes, we did provide a link in chat for you to access the recording of Part 1 if you were unable to view it. Again, there will also be a recording of this webinar, as is for all of our webinars. You can access them on our website, healthcarefornewengland.org. We also have another question in chat from Vincent. Hanover Terrence, we are also alarm-free. Alarms only tell us when it's happened and does not prevent. So sometimes the staff becomes, and sometimes staff become relaxed. I guess that's a comment from the previous presentation or question. We also have a comment from Tara in chat. Purposeful rounding is a great way to replace alarms. Look at a YouTube video. Tara, if you have the link to that YouTube video, if you could link that in our chat so that folks can watch the video that you're referring to, that would be wonderful. We could also, if you can't get that on time before the end of the webinar, if you could email that to us later on, we'll send a slide with our email addresses. Feel free to email it to us, and then we can also include that link on our email that goes out tomorrow after the webinar with any resources that we'll be sending to you all.
So did you see the question from Martha?
Scrolling up now. Yep, okay, so when is the best time to check the CASPER report for accuracy so we can correct them if we need to? Great question. Florence, would you like to answer that one?
That is a very good question.
This is Katie. There is a report that's sent out by, if you don't want it to permanently stick in that new monthly quality measure report, quarterly before the release of that data, CMS sends out a special report to show you what is going to be projected in your next new monthly report. And that comes out usually between the 15th and 17th prior to that quarter data being released. And it's really challenging right now because they keep pushing back the when they're going to release that next quarterly update.
Like Sarah said, if you can send us that YouTube video. So in here I'm saying, like,
I guess you guys, someone wasn't on mute, but I think that they muted themselves. Katie, are you still on?
I am. Did that answer the question?
Okay. Thank you. We also have another comment in chat from Vincent at Hanover Terrence. He also said that another thing that they do as well for the team is that they increase activities for the residents, which is also a great idea. Vincent, if you have some examples of activities that you'd like to share via chat, or if you want to unmute your line by pressing #6, we would love to hear some examples. And again, for anyone else that has a question or a comment, or if you'd like to share a best practice or story from a successful tip that you've implemented, we'd love to hear from you. Please dial #6 to unmute your line. All right, in the meantime, while you come up with your questions, I did want to go back. We have one more polling question. So if we could start the poll. Have you developed your PIP team? simple answer, either yes or no. And if the answer is yes, if you could please share with us in chat what the specific PIP goal is and who you have as part of that PIP team. So that's 2 steps. Answer the polling question. Make sure when you answer yes or no, you click the submit button at the bottom. And then also, if your answer is yes, if you could submit some more details about your PIP goal and who is actually on that team in chat. We'd love to hear from you. We also have a comment from Jamie in chat who said we are implementing a program of activities for staff and family to use individually or as a small group. That's a great suggestion. All right, so the poll has closed. It looks like 14 of you said yes, 13 said no, not yet, and then for those of you who answered, we'd love to hear from you in chat. Jamie also shared in chat a great website for materials. It's called activeminds.org. Check out the link in chat. Thank you, Jamie, for sharing that with us. Do we have somebody on the line that has a question?
This is Vincent. I wanted to comment on the activities.
Oh, thanks. Hi, Vincent.
Hi. So this is Vincent from Hanover Terrace. It's a nursing home in Hanover. So one way that we did also is to increase the activities. We hired more staff. We call them like unit aides. And also we had activities because most of the falls happen in the evenings that we discovered in our building. So after supper, people want to go to bed, people want to go to the bathroom, and that's when we end up having more falls. So we had some activities like videos. We could do some group activities too, one-on-one, so that we give time for the aides, the NNAs, to get people to bed and also toileting. So it reduced a lot of falls and also to eliminate alarms in the building.
Thank you, Vincent. That's great. Are you able to quantify what your improvement was for reducing falls and eliminate, how many alarms were you able to eliminate? 100% or?
Oh, 100%. We took, like you said, we had also challenges from the staff, some people would, just put them, but with the help of the unit aides, nurse managers, and the group, we worked so hard. So it took us like a month and a half, and right now it's 100%. We don't have any alarms, and the fall incidents have gone low,
Excellent. Congratulations. Thank you.
Thank you.
Tony also said in chat that they've also reduced their falls after supper hours by also having evening activities. So it sounds like a best practice. Thank you all for sharing that. We have another question in chat from Evelyn. How can you identify the date of the nursing home compare report? Where is the date located? Katie, can you answer that one? The question specific to the report. We're referring to the Casper reports.
Yeah, it used to be really easy. So the Casper report you can pull whenever you want to. The new monthly reports that is on that located where the Casper reports are located that come out from CMS. It used to be really easy to tell when they were going to send that updated information, but they don't really have their stuff together right now, so it isn't easy to tell. Basically, it's supposed to be a month before the data gets released. So technically, Q4 data is supposed to be released this month, so that little preview report would have gone out a couple weeks ago. And again, it's usually between like the 10th and the 17th, so you just have to keep looking for the preview report. And that's the only time you really, the last amount of time that you have to correct that before it becomes really public record and you can't change it. But if you're pulling your Casper reports regularly, you should be able to identify it before it becomes a permanent problem. Thank you, Katie. That's a good piece of advice.
Does anybody else have any questions that they wanted to enter in chat or join on the phone before we wrap things up?
Hello?
Hello?
Hi, this is Bruce from Branford Hills Healthcare Center. You had asked us to put down some of the QAPI agendas that we're currently working on.
Mm-hmm.
Right? So what we noticed was that we had, using our CASPER report, that we had triggered for increase in ADL assistance with a long-term care population. So we developed a QAPI team we went out there and we spoke to the CNAs, and we found out that they didn't have a clear understanding of what the definitions were. I mean, they're working off of kiosks, which has all the information in it. But we found out that they weren't really reading it. They were just working off of their preconceived definitions based upon the definitions of years ago. And so they were actually not coding correctly because they weren't up to date on the definitions of all of the choices. So we put together a workbook, and we took all of the areas that are in Section G, and we also put bathing in it as well, and just have nice, clear-cut pages. Number one, what is the definition of personal hygiene? And then from the RAI manual, where they have scenarios, we printed those exact scenarios right from the RAI manual and put them in the handbook to give people examples. And then we have a handbook for every unit, for every MDS coordinator, and for our education staff person. That's what we're working on right now.
Excellent. Quite impressed, Bruce. Thank you so much for joining the call and sharing that.
Thank you.
We have time for one more question. We have a question from Qapi on chat. This is, again, for Katie at Beechwood. How were you able to do so many PIP projects at once in a small facility? It would seem that the same people would be on multiple projects, and with the amount of time it takes to do these projects, it could impact job performance on their other duties. Katie, can you expand on that and share how you guys were able to be successful with working on so many PIPs?
All I can say to that is we have a really good team. We bust our behinds, and everyone wears multiple hats. We are small, but I do think that helps us because it is the same people involved, and we're all out on the floors, and we're all looking at everything. And I can say out of all those projects, usually 2 or 3 of them are going on at the same time, and do touch on different areas and different pieces. We try and pull different nurses into it or different CNAs into it, different housekeeping members to attempt to get everybody involved, depending on whatever the project itself is. But we have some very, very tired people.
Hi, it's Florence, and I will attest I visited Beechwood, and they truly are they are so polished with what they're doing. They use data to drive their work, and everybody has bought in. Everybody has had a sip of that Kool-Aid, and they truly do believe in what they're doing.
This is Sandy. I have worked with a number of facilities who put people on their PIP team, not only if they're directly related to the resident that may have the issue or the incident, but people who want to be there. Now, the PIP team doesn't have to be, it could be 3 or more people. It could have 3 people, but one facility I was on, the maintenance man wanted to be on the PIP team, and on another facility, one of the dietitians wanted to be on it. That's perfectly fine. It does not have to be just your nursing staff and your CNAs. You get people, and they come in with fresh ideas, and you can put them on that PIP team.
Thank you, Sandy. Thank you all for the great questions and discussion. I just wanted to highlight before we get off this webinar that we do have several upcoming events listed here on the slide. We have part 3 of the 6-part webinar series on antimicrobial stewardship. This one will be focusing on discussions about UTIs. If you have missed the first 2, you can always access recordings on our website. The link is in chat from the question earlier on how to access recordings. We also have 2 face-to-face events. They're pain seminars with guest speaker Carol Curtis. She's a nationally known expert speaker on pain management. You will find a save the date that will be going out soon, and you'll be able to find out how to register for those soon. And then we do have an upcoming affinity group that you can register for, which is focusing on incontinence. These are 4 one-hour monthly calls with guest speakers and experts in that subject, and we share best practices and come up with action plans each month. And that group is starting next month on the 18th. If you do have any questions, please contact your state lead. Emails and contact names are here on this screen. I do have a few last announcements before we end the webinar. You will receive a follow-up email with a link to a very brief survey about today's webinar. We ask that you would please complete it. This is very important. Your feedback can help improve these sessions and provide you with meaningful programs in the future. Also, within the next few business days, we will send out an email to everyone that contains a link to both today's presentation and a recording of the webinar. Again, if you haven't followed us yet on social media, check us out on Facebook, LinkedIn, YouTube to stay up to date on what's going on in healthcare, learn about events and educational opportunities, access videos, and more information from the New England QIN-QIO. And finally, if you do have interest in one of the 2 pain conferences in June, we are doing a contest to win 2 complimentary entries to the date of your choice, one for yourself and another for a colleague. All you have to do to enter to win this contest is to find us on Facebook. Just look up the New England QIN-QIO. There's also a link here on this slide. And all you have to do is like us. So please find us on Facebook, like us, and thank you all for joining us today. We had some great discussion, and have a great rest of your week.